So Alice, now I would like to discuss the topic, how do we treat older patients? So discussing maybe cessation of a certain treatment or a de-escalation approach. What is your opinion concerning this topic?
So these are the patients, this is sort of a problem that's developed with the more highly effective treatment. So when we have platform therapies that aren't that associated with severe side effects, when patients become older, we can tolerate the platform therapies because they are limited in the severity of their side effects. However, the highly effective treatments like ocrelizumab, ofatumumab, etc., they have a more relevant risk with increased age. So B cells in your body, obviously they are important for the development of MS or for the inflammation in MS, but they also have important roles in surveillance of the body for cancer cells and surveillance for infection. And as you get older, your immune system changes. And as you get older, your risk of developing cancer also just naturally increases through many factors. And you have to start having the discussion with patients maybe above the 60 years old time point. So we are meeting each other maybe for the 30th time in clinic. We've had follow-ups for the past 15 years, twice a year. And for the past 10 years, it's always been the same discussion. Things are great, I'm fine under therapy, no progression, no relapses, MRIs are all the same. So you've got a long time of stability. And these are the patients with whom you can discuss comfortably, saying, well, have you had more infections in recent years? And they say, well, actually now when I get a cold, it really affects me and I'm off work for 3 weeks, twice a year. And that never used to be the case when I was younger. Or they say, yeah, my dermatologist just removed 2 skin cancers last week. And you think, oh, okay. And we're giving you a therapy every 6 months that really reduces your body's capacity of removing cancer cells. And then you think, is it worth giving this treatment for further years when we know that this patient is stable? And we know that there have been some studies that show, there's been a study that shows above the 60 mark that actually in the majority of patients, if you stop treatment, they will keep being stable. There's obviously then maybe 10% of patients that will have further relapses, but there's a large number of patients that will remain stable, and you think, okay, likelihood is that this patient will be in the 90% that then stay stable, and that's definitely worth discussing with the patient whether or not we just stop treatment. The de-escalation aspect is a bit more complicated because we really don't have any data on that or any really strong data on that. If a patient says, I'm really scared about stopping ocrelizumab and I want to have something in the background against MS, and we would then say, hey Sven, we've got a case for you. This patient doesn't want to completely stop treatment, maybe we can switch them to something else. We discuss that within the department and whether or not de-escalation in that case is something that we would offer. So it's a bit of a complex topic. There are lots of unanswered questions, but definitely getting above the 60 mark, the risks and benefits discussion changes, and that has to be something that's dynamically discussed in the outpatient clinic.
Yeah, I have 2 additional questions. I mean, you mentioned this de-escalation approach, and I think your example with a B-cell depleting therapy was maybe the easiest one.
Yeah.
Because if you stop B-cell depletion, the reoccurrence of the B-cell takes a pretty long time.
Yeah.
So if you have maybe a less effective therapy as a de-escalation strategy, this agent still has the chance to act on an immune system where the B cells are returning slowly over time, which is a completely different discussion compared to natalizumab, where we know if we stop treatment now, we will most likely have a significant relapse, maybe even a rebound of disease activity within the next 2 or 3 months. So I think de-escalation is really something we cannot answer with a general study. We really need a sequence of therapies studied in a way or in a cohort to make the difference between coming from natalizumab, from S1P modulation, from cladribine, and or from a B-cell depletion. And concerning cessation of treatment at the age of 60 or older, there's also a discussion coming from a paper from the US where people were asking, do we stop these treatments because we are afraid of comorbidities? You mentioned cancer, but also maybe metabolic disorders or cardiovascular disorders. Or should we continue treatment to prevent, let's say, reoccurrence of subthreshold inflammation in the body to work in a positive way on these comorbidities?
Which is crazy.
Yeah, it's somehow turning the whole discussion by 180 degrees.
Crazy in a good way.
Crazy in a good way, or at least interesting, right?
So interesting, and this is like a modern branch of medicine that's opening up this whole body inflammation, this meta-inflammation, and to think that, you know, you're treating an autoimmune disease, and to think that someone's come across this idea of broadening that out to treat a whole body inflammation, it's just really exciting new science that's going to take us forward across the board. And we both, as neurologists, are two neurologists who are actually very interested in the body as a whole and how this interaction takes place. So I think we'll both be refreshing our inboxes for the newest papers in that area.
Thank you.
Thanks.